My name is Darshan Mehta. I'm the Education Director for the Osher Center for Integrative Medicine, and welcome to our Grand Rounds presentation this morning. Before I introduce our esteemed speaker, I just wanted to highlight a few things. One is we have the Osher Center Integrative Medicine Network Forum, entitled The Lived Experience of Depression and Integrative Approach. This is on November 10th and 11th. It's a virtual meeting, and we are really excited to have a tremendous panel of distinguished speakers and luminaries. This conference is free. We encourage you to attend. We will be putting the registration link here in the chat just in a moment. And so again, we would invite you to join. This is going to be a wonderful two-day event as well. So with that, and then our Grand Rounds next month will be Dr. Maren Nair from Massachusetts General Hospital on talking about the role of hyperthermia in the treatment of depression. So that I'm going to introduce my friend and colleague, Dr. Paula Gardiner, who's based at multiple institutions, but most recently, it's hard to keep all of her titles, is based also at the Center for Mindfulness and Compassion at Cambridge Health Alliance. She's associate professor at University of Massachusetts Medical Center and has done tremendous amounts of work in multiple areas. My first paper was written with Paula, so it's been hard to believe that we've come now 17 years later, but here we are. So Paula, I'm going to turn over to you. She has a long bio, so we're most excited to hear her comments and thoughts. So Paula, we'll turn it over to you.
Well, thank you, Darshan, so much. It's definitely like coming home. It's always a big family reunion for the Osher community, and as you said, we both did our fellowship together, and it's, you know, I've really been enjoying your speaker series this year, seeing other colleagues as well. So just such a shout out to the Osher community. And what I really wanted to be talking about today is how is it that clinician integrative providers can move into clinical settings in a way that the work is meaningful, we're able to do social justice, and then how can that integration really bring in new models of care? And I titled my talk, "The Doctor Will Meditate with You Now," meaning like when I was little, the nurse would come out to the waiting room and say, "The doctor will see you now." And so I was thinking about this idea of, wow, what would it be like? What would the paradigm be like if you did go to a healthcare community and you were going to an exam room and they said, "Well, the doctor will meditate with you now." It just feels so inspiring to really bridge these two ideas of allopathic medicine at the point of care with truly integrative techniques, evidence-based, in that the clinician is providing them, in that the nurse, the doctor, the social worker, the meditation teacher are providing them in the point of care. So the first thing I wanted to do was to do some meditation, because in our medical group visit projects that we do, this is the way we start. This is the way we start. So what I'd love to do is to actually invite you to get comfortable in your chair. Like, think about where you are in your space and start by just looking around the room and starting to notice colors, shapes, sounds. And if you want to close your eyes, you can, or you can just have a gentle gaze down. And now bringing an awareness to the breath, just start by taking a few deep breaths in and out. And as you're breathing, see if you can notice, how does the air feel at the tip of the nose as you're breathing in and breathing out? So breathing in, breathing out, and seeing if you can just soften the face a little bit, soften the neck, the chest, and even by now placing the hands over the chest or the hands on the jaw. Bring the awareness of that beautiful warmth underneath the hands. And this is creating, recognizing, growing compassion. The warmth of the hands representing beautiful, supportive compassion. And then when you're ready, we're going to open our eyes, start to move our fingers around and do a beautiful stretch to the sky. And exhaling. Beautiful. And then finally, shaking out the hands. Okay, beautiful. Such a beautiful way to start the day. Now for my talk, I wanted to use a few slides, but not a ton of slides, so that we could really be engaged. And what I'm going to do first is let me share my screen. Okay, here we go. So here, start the slides. And what I'll do is I will go to slideshow and from the beginning. Okay. So again, I want to be in dialogue with our community. So I'm just going to show a few slides and then we'll
you're in
which, oh, okay.
Just flip the top, yeah, just
Let me try again.
the others, yeah.
Okay, so share screen. And there we go. Does that work?
Yeah, there we go. Perfect.
Okay, thank you so much. Okay, so I have nothing to disclose. And yes, I'm happy to share my slides. And yes, I'm happy to share my resources. So this has really been a journey for me. And I want to share my journey with you, my 17-year journey since I finished my fellowship at Osher. And so I want to do 3 acts, like a play. I'm going to do 3 acts. The first act is, how was it about creating this framework and defining what is a group visit, and how group visits have actually been part of the fabric of allopathic medicine for a while. Discuss what have the barriers been for bringing these groups in. And then the third is to talk about the Optimum study as a model. And the Optimum study is an NIH-funded study from the HEAL grant that's done with the community. Okay. So the first thing is that I know not everybody knows what a group medical visit is. So let me just start from the beginning. So this is me on a typical clinical day where I am seeing patients one at a time, going from room to room to room. Now I'm usually late. So I'm going from room to room to room, seeing patients individually. And what the group does is actually puts the clinician in the circle with the patient. So here I'm seeing patients, maybe 8 to 12 patients in a group. Now with COVID, many of our groups have moved online because of safety precautions. So nowadays, some groups are being done in person, and some of them are being done online using telemedicine platforms like Zoom or WebEx. And I also wanted to say that a group visit has many different aspects to it. It's got the idea of a check-in where the patients come in and they're doing their own blood pressure, their pulses, they're filling out a check-in form, and they are assessing their own body, assessing their own health. Then we have the aspect of EMR and having a clinician. Now, this is all happening in front of other people. So the clinician is talking about what's going on with a patient and providing a physical exam in front of other patients. And that is done through consent. So everybody agrees it's okay for medical information to be discussed. Then there's some type of mind-body practice, some type of meditation or centering exercise, and usually a health topic. So this happens to be about sleep or insomnia. There could be some type of experiential like hand massage or yoga, tai chi, and could even be a discussion about healthy eating. So this sort of gives you like a minute by minute breakdown about what a group visit, an integrated group visit would be, right? And how the timing of that might work. The other thing about group visits is that it stretches what we think of in terms of clinical space. And hopefully you can see my cursor where here's the reception area. The patient would come into the group space. And you can see that it's a large space enough to have chairs in a circle. And if needed, the physician has an office off the side where they can see patients individually if needed. So a patient might come in, interact with a medical assistant, and then come to the group space. So over the years, we've really been developing what is it unique about that integrated care. And we have created 2 different models, my team and I, around mapping what happens in that integrated group visit. So the first map we created is the biopsychosocial model of group visits, where we have the individual level, the interpersonal level, the organizational level, and the community level. And so from the individual perspective, what is it? What is that special sauce, that uniqueness that is in a group that's not found in an individual visit? And from the individual's perspective, being in the group, what is going on? Well, one is that they're developing self-efficacy and self-regulation of their emotions. The other thing is that they're with other people who have a similar condition. So they are not alone. They are not alone in their pain. They are not alone in their diabetes. They're not alone if they have cancer. You know, they're not alone if they have migraine. They are in a community. And that helps them engage in their life. And because the group is building skills, there is skill acquisition. There is skill building such as meditation, or skill building such as eating a recipe that is done in the group. There's also this idea of creating agency, where the person is really noticing that they are in charge of their body. The body is not in charge of them. The medical system is not in charge of them, right? So we see this over and over and over again in our research on medical group visits. The next level is this interpersonal level. And that is actually that the clinician and the patient begin to be at the same level, that we're moving beyond a hierarchical level of decision-making, but actually into a shared decision-making, where that the patient and the doctor have equal power in the group. So for me, when I run groups, I don't wear a white coat, you know, and my patients call me Paula, or they call me Dr. Paula, and I sit at the same level of the patients. When I am leading a meditation, the patients are meditating, right? Or maybe somebody else is leading a meditation, I will be meditating, meaning that I am being part of the group. And that is increasing affiliation, it's increasing universality, altruism, right? Since the patients have equal power, they also can be the teachers, they also can be the helpers. They can create altruism and this social integration and support. And then, of course, there is interpersonal learning. Now, from an organizational perspective, what the group visit's doing is increasing access. So you've got time for timely care for self-service, timely care for health service navigation, meaning we can bring speakers into our group. So the group I'm running at Cambridge Health Alliance, we're bringing in a patient advocate. We're bringing in a physical therapist. We're bringing in a dietitian, right? We're accessing the community resources through the group. And that creates a larger support network for our larger community, right? Because they're building resources. And then this slide I just wanted to say was from our research in our Patient-Centered Outcome Research Institute study, our PCORI study, where we from this that randomized controlled trial, we were able to build a larger framework about how do group visits work. And they're building self-efficacy. So one of the things that this research was talking about was chronic pain. And so actually we saw patients move more, actually move their bodies more, and noticing what's going on in their bodies. So in essence, they ended up using less medication, less pain medication because of that. There is an access of stress management that comes from the group with improved coping and reducing depression. That group visits offer patient health education, which reduces stigma and improves health behavior. It increases access to care, which then has the patient be the self-advocate and communication with the clinician, and social support, which reduces social isolation. So I have to say that from all the focus groups we did, when you ask what is the most important thing for you in your health journey that the group has brought, and they would say it's the community, right? The most important thing is the peers, the community. So this is sort of what a group visit looks like now with Zoom during the pandemic. Now, I just wanted to briefly talk a little bit more about what is going on with the evidence around group visits, like how are these integrative group visits expanding? And the first slide I just wanted to say was, group visits have been around for a really, really long time. They were around in the 70s. Currently, the Veterans Administration, there are I think there are approximately 52 VA hospital systems in the US right now, and each one of them has a medical group visits. Group visits, are part of the fabric of the VA. And then there are models like Centering Pregnancy, which are involved in a prenatal group visit, and they are actually in about 500 hospital systems. Large hospital systems like Kaiser Permanente, Mayo Clinic, Cleveland Clinic, all have group visits. So group visits are becoming really part of the fabric of allopathic medicine. And what we're trying to figure out is how do you bring evidence-based integrative medicine into them? So the group visit itself increases the access and the amount of time with the clinician. It increases patient satisfaction. It reduces health utilization like emergency room visits. It increases medication adherence. It increases health behaviors and quality of life, and decreases disease-specific outcomes. And this is a research study that my group did, where we were able actually to show that group visits have many different names, right? It could be an SMA, or shared medical appointment, to a group office visit. So when you're thinking about this, it can be called more than one thing. And the literature, the evidence of it is increasing. Even models like the Diabetes Prevention Program, which is a group, that research is increasing. And then finally, geographically, you can see most of the group visit research has been done on the East Coast and the West Coast. Okay, so now I wanted to switch gears and sort of talk more now about, well, what is going on nationally, right? How are we as a community trying to think about this model and bringing it into our clinical settings. So Jeff Geller and myself, along with a group of really amazing people, have started a nonprofit organization called the Integrated Center for Group Medical Visits. And basically what our mission is to teach people how to run group visits. And we have been having conferences. We just had our second conference. And what I wanted to share was the data that we had collected. This is unpublished data. This data was collected from the people who came to our conference. And we put out a town hall Delphi process, meaning that as people were registering, we were asking them what are their biggest priorities around group visits. And then we had a town hall that again asked people, well, what are the priorities around group visits, bringing integrative medicine in? What are the big features? So first of all, I just wanted to say that integrated group visits now are being found all over the nation, which is awesome. Organizations like the Consortium, the American College of Lifestyle Medicine, the naturopathic medicine community, integrative oncology, the Center for Mind-Body Medicine, our colleagues in the Academy of Integrative Health and Medicine. So we can see a wide range of different types of organizations providing training. The other thing we asked was, okay, well, what are the different sites that the integrative groups are starting to happen? And the reason why this is important is that because when you're doing an integrative group, you can bill, the MD, the nurse practitioner, the PA, the social worker, the psychologist can bill. It allows you to bring in a therapy that isn't normally covered by insurance, right? So I can bill for the group as a doctor, but yet the patients can learn meditation. I can bill for the group as a doctor and patients can learn Tai Chi. So we wanted to know, well, where is this happening? And you can see that actually the community health centers and the federally qualified health centers are, we had 26 people represented there. And that is so important because that means that is a way of creating access to low-income patients who normally couldn't afford that because of out-of-pocket payment to start to get integrative group visits. And then also the second largest is the large academic medical systems. Okay, now when we're talking about groups, one really important thing is this billing model, right? How do you pay? If we can't pay for this, break even, make money, then it's not going to happen. So we were really interested in this idea of billing and how are people billing. And still what's going on now is that people are on the majority still using individual billing codes and for these individual patient codes. So they're billing for seeing patients one-on-one in a group setting. Some people are using co-pays, some people are using out of pocket, some people aren't charging at all. And then also we want to know, well, what is your overall business model, right? Your overall business model for groups. And here you can see the majority of people, again, are using fee for service. Now, just to clarify, Medicaid, Medicare at this moment has no unique billing code for a integrated medical visit, right? They have billing codes now for the diabetes prevention program. They have billing codes for behavioral health therapy, psychotherapy groups, but not for a medical group visit. Now, just to do a quick shout out that you can see on this list are concierge model, bundled payment, for example, pregnancy, and that's a great model. That's what the centering pregnancy community is using, is this idea of you give one payment for all the care. And also you see grant funding, philanthropy, but this new and emerging idea of ACOs and accountable care organizations and bundled payment really allows us to think about how to care for patients in a different way using groups. Okay, so then we also wanted to talk about infrastructure and internal factors and barriers, right? So what are the biggest barriers right now for successful groups in the practice? And what our participants said was, hey, believe it or not, the clinical practices don't provide the staff support. They're not, and the staff are not effectively trained, and there's concerns about billing compliance. And then also a big concern is recruitment techniques, because you need to bring a lot of patients into the group to make sure that you're billing appropriately to break even. Now, another thing that happened was during COVID, right? During COVID, there was a big shift to in-person groups and online groups. So this data was collected during COVID, and the first thing we're talking about are in-person groups. What barriers do you think it makes difficult for your patients to come to an in-person group? And you can see the number one was work and other responsibilities, childcare and family care responsibilities, and fear of catching COVID. Those were the big things. Transportation and parking. And what's really cool is that when the groups came online and we started doing medical group visits online, we saw that it overcome the transportation barrier, right? It overcame the childcare, because you can be at home with your kids and on the group visit. But you'll see here that being online, there's no access to a device became difficult for patients to attend. No access and internet became a key issue, and low technology skill use. And then also difficulty having private space in a living situation. So what is going on here is the digital divide. What is going on here is that there needed to be a whole new set of skills in educating patients about using technology and getting them up and running, getting their devices, getting them internet access, and making sure that they have the skills that are needed to be on the group visit using video conferencing. And so if we did this survey for our conference that was about a week ago, and when I look at that data, it probably will be different, right? Because it's been a year into the pandemic, and we as clinicians are getting better and better about getting the support staff we need and training our patients to use technology and trying to find ways for them to get access. The other organization that's been really working on group visits and also is very concerned about this integrative medicine for low-income patients populations is the Integrative Medicine for the Underserved. And every year they do access and medical group visits. So there, I just want to give them a shout out. They're doing their 2022 annual conference this October. And I had a chance to look at their conference protocol or conference agenda, and it is amazing. It's amazing. So just a shout out for IM for Us. Okay, so Act 3, this is the last thing that I want to talk about. Let me just grab a quick sip. And actually, why don't we all just take a quick stretch, just an invitation to stretch up to the sky and move any way your body needs, just a quick stretch. We've been sitting for a little bit. Good. Okay. Okay, good. So Act 3, here we go. Okay, so now we're talking about integration of groups that have mindfulness in them. So I have such the pleasure, such the gift of being part of this HEAL initiative randomized controlled trial. And this is the Optimum study. It's an NIH HEAL grant, and Optimum stands for Optimizing Pain Treatment in Medical Settings team. And this is our team. Amazing Natalia Morone from Boston Medical Center is our PI, and we have people from all over the country helping us. So let me give you a little bit of background about the why mindfulness as a way of really doing the rigorous research about how to bring the groups in. So as you know, mindfulness is effective for low back pain, and mindfulness right now, MBSR, mindfulness-based stress reduction, is not currently reimbursed in a medical setting. So what we're trying to do is figure out, how do you bring MBSR into a medical group visit as a way of allowing patients to get that evidence-based treatment in a real life setting that's covered by insurance. So I just wanted to share the aims of the study, because the study is now entering its halfway mark. So I don't have any results to share, but I did want to talk about the study as a model of studying integration. So the first aim we have accomplished, and that is to plan and test a mindfulness clinical pain management program, adapted MBSR, into 3 health centers. And then the second aim was a randomized controlled trial with 450 people with chronic low back pain. And they're going to be randomized to either the mindful medical group visits or primary care. So our hypothesis is that we are actually going to improve pain intensity and interference by using the PEG validated score, and that will be completed at 6 and 12 months compared to usual care. Now, I am so excited to talk about our 3 sites, because there are 3 unique different sites. Boston Medical Center is a safety net hospital, and it is actually the largest safety net hospital in New England, and it cares for about 60 to 70% Medicaid patients. It's a very racially diverse patient population as well. And it is located downtown in the inner city. University of Pittsburgh is a large academic health system, and it has more private pay insurance patients. And University of North Carolina, Chapel Hill is in partnership with the Piedmont Health Services, which is a federally funded health center, and actually has a more rural patient population where there's not a lot of broadband internet and availability of technology. So currently all of the group visits, because of COVID, were transitioned online. So basically what we're doing is we're doing a model of basically adapted MBSR in 8 weekly 90-minute sessions of a group-based billed by clinical person. Now, because of the different patient populations, some of the groups are not charging, not billing, but some of the groups are being billed. And it's being delivered through primary care medical group visit model. So what does that mean? Well, it means right now being delivered by telemedicine. There is a clinician there and an MBSR instructor working together as a team. And the patients are arriving via the video, right? They're logging on to Zoom, they're logging onto the platform. And so we're all on the screen together, and the patients are being met and going to an individual breakout room with the clinician, either before or after the group, to get that one-on-one medical group, I'm sorry, one-on-one clinical care. But the provider is there during the mindfulness. The billing provider is there during the meditation and there during the overall group. and that provider is documenting in the electronic medical record. Now, the control is just usual primary care, so they're not doing any sort of non-pharmacological approaches. And I just wanted to give just a quick list of all the different kinds of things that we're measuring, like the Promise 29, depression, current opioid use demographics, so many different types of things. But we're also doing, at the end, exit interviews. And those interviews are talking with the patient about, well, how did you feel about the group? And what do you think about confidentiality? And how was that for you to be in a group with a clinician? And then finally, we're even looking at EHR data from the medical record. And here we're looking at opioid prescriptions, MRIs, surgeries, hospitalizations, basically the costs, right? The different services and costs, to see if the group is going to reduce these. And then finally, I just wanted to end by providing a couple of beautiful quotes from the participants so far. These are from our focus groups with our participants. So one of them says, but no, you can't always meditate in quiet places. You could be on that bus, but the garden is in my head. So I have something to kind of focus on and kind of weed the garden out. Weed the people being ignorant, making all kinds of noise. And I just sit here and I am in this place and I stay there. Sometimes it don't work now, but that's where I like to go. And I could do that in a class setting, no problem. I learned how to do it now. Another participant writes or says, you know, I know how I feel. I know how the meditation makes me feel. I think others around me, I'm not 100% sure, but I think they see, not even see, they can feel the change in me already. You know, maybe I'm not so quick to argue anymore, you know. I don't know what they see, but they notice the change. And then the last quote I wanted to say is, you know, knowing that there's a new avenue I can walk down to escape. You know, the doldrums of life, and when you feel like closed in, and it can be kind of like just opening things up for you a little bit, make you more aware of what's going on in your body. It's done that for me, but that's about it. So it's good to do it, man, because that actually, the meditation actually allows you to escape from the doldrums, from the drama, from the, you know, things that are against you having a normal, happy life. It kind of enhances your life. Okay, fantastic. So I wanted to make sure I give plenty of time for questions, and people are always welcome to email me at pgardine@challiance.org, but I'm going to stop the share and invite Darshan to come. Hi, Darshan, great. Thanks for coming back.
Really stimulating, just, you know, stimulating some ideas for us and thinking about really evolving clinical models of care. So let me, you know, one of the things that you brought up in your early on in your presentation was just how you chose language and how language matters. One of the questions asked here is that the word patient itself is associated with the imbalance of power in the medical system. Have you thought of using a different word, or are you still staying with patient?
Oh, yes. I think that that's totally on the money, right? That the word patient is imbalancing in power. So thank you for the person who asked the question. In our groups, we refer to them as participants. Now, do we call them participants because we are a research organization and we're thinking about community-based participatory research, which is the model that we like to do most of our research. But there is an emphasis of equality in the group. And I think that really noticing the language is so important. But I have to say that when the staff talks, we are in a clinical setting when we're running the groups, right? We're in the family medicine clinic or around the country. I have to ask my colleagues. So we are in a setting where the water that we swim in is referring to people as patients, not clients, not not a different word. So, but when we're in the group with people, we refer to them as participants.
Through this, leading groups is a special skill and requires training. And maybe how do you, and I know you're leading a lot of trainings around this. So what are the two parts to this question? The first part is, what is your current training? How do people get trained in leading groups? And the second thing is, how might school in all health professions, and obviously some questions will be more focused on medical school, but also thinking in the other health professions, including some of the integrative health professions, like what type of training is going to be required?
Well, thank you. That's such a beautiful question. And we are right now at Cambridge Health Alliance testing models of training. On Thursday mornings, we have a integrated group acupuncture clinic with the New England School of Acupuncture students. So if you imagine a large conference room, half the conference room has chairs in a circle and the other half has acupuncture tables. And there are 4 New England School of Acupuncture students and their preceptor working with me and the Tufts medical students, or maybe there's a resident there. And so, we have like 6 to 7 staff all trying to care for these patients in an integrated way. So I think that not only are we training our allopathic students in running group visits, but it's also so important that the other professions, naturopaths, acupuncturists, massage therapists, diet nutritionists, Tai Chi teachers, like all of these different groups are needing to create curriculum around working in groups. It's basically working in an integrated team, right? We are working together in an integrated team. So for myself, I think that to me, bringing in the undergrads, bringing in the medical students, bringing in the naturopathic students, bringing into the medical system to have them train is really important. But right now we are trying to figure out what is the best way to train. So, people are welcome always to come to the Integrated Center for group medical visits. Jeff Geller and I are doing training all the time. But, many organizations now are starting to offer training in group visits and also training for, as clinicians build their skills, I suggest that they really engage in a modality themselves, like, take an MBSR class, take a Tai Chi class, get a massage, go for an acupuncture, like really experience those modalities, and that will help give them a basis from which to talk to. I hope that is good.
More, because as we think about integrative health, broadly speaking, and do you see that there is a role for group medical visits with other types of practitioners, acupuncturists, chiropractic care providers? Do they also, how do you envision them being both part of the group medical visit model and being trained in the group medical visit model?
Well, how do I envision non-billing providers to get trained? And I think what I'm trying to say is that as long as you can breathe, as long as you can have a caring heart, you can get trained in running a group visit. So there's a skill set. Absolutely, there's a skill set, just like there's a skill set for writing a prescription or leading a meditation. So for the integrated schools, the chiropractic schools, the naturopathic schools, to start to adopt curriculum on running groups. But many of these traditions, like, for example, acupuncture and community-based acupuncture, or somebody who's running a yoga class, somebody who's running a class where the modality is done in a group, right? That there's something about having people together in practice that has benefits as well. And that's it's just always interesting to me. Like, for example, meditation. Let's just take meditation. You know, when John Kabat-Zinn started MBSR over 50 years ago, he decided to do that in a group, right? So there's, I think, certain modalities that have always been done in group settings, and that in itself has an enhancement that we are trying to figure out how to study. How is it that being together in community, does it change the physiology being in a group? Does it change the brain being in a group? How do mirror neurons work? What happens to my physiology if somebody next to me is meditating as opposed to me being alone, right? So I think, you know, we're just beginning to really try to understand how to study the science of this. But I totally think that any person can get trained to do a group visit.
We obviously, you've talked a lot about the positive effects of the group. One of the questions I was asked is, are there experiences with people just bringing the group down, and how do you screen for maybe this is not the right member for a group?
Fantastic. And group visits are not for everyone, 100%. So, because not everybody wants to be in a group, and that's completely okay. It's really talking, you know, we do screen before patients come, and there are a few, you know, a few characteristics or states that we really discourage patients to coming to the group at this moment. So, for example, we screen for active substance use. We screen for, you know, active suicide ideation. You know, there are times where when someone comes in to the group and disrupts the safety of the group, where the groups are not a good match for them. But I have seen groups, you know, where can handle very difficult situations. So at Cambridge Health Alliance, where I am, we have a very active program in Suboxone group visits for patients who have opioid use disorder or heroin use. And this is a group of patients that are meeting every week and supporting each other, getting their prescriptions for Suboxone. And I think, you know, they have at any one time 14 different group visits running around the Suboxone use. So the facilitator is really setting an intention around safety and confidentiality and ground rules. And if the participant doesn't feel like they can follow the ground rules, they'll be asked to leave. And we do need to make sure we know that everybody in the group is safe.
In a group.
At the very first session, we talk about the importance of confidentiality, and we have a HIPAA compliance form that all of our patients sign, and that basically says, I agree it's okay for me to be in a space where medical information is being shared. And I know that I can share medical information. I know you might share medical information, and I agree to keep it confidential. Now, I've been running groups for, gosh, 15 years, and I've never had a problem. And then if you look in the literature right now, there are basically 3 papers that address it. In our Optimum study, we are asking questions about confidentiality. So overall, I would say that, you know, just like there's a risk for any medical confidentiality, you know, even when you're talking to your doctor or being in a medical situation, somebody might be discussing your health information. So I don't feel like the risk is greater being in the group.
How do you strike a balance between patients who need sort of one-on-one discussion versus sort of the individual versus the group? Like, how do you judge that in the context of these group settings?
Well, one way we do it is that our groups tend to have common themes. So, for example, we might have the theme of chronic pain. We might have the theme of living well. Actually, the name of our group is Living Well with Chronic Pain, or Living Well with Diabetes. This idea that, you know, that often groups have some sort of central theme. It could be a living well with a healthy body. So we're just embarking on a group of group visits for people with body image issues or obesity, and wanting to be in a group of a body positivity to really talk about what does it mean to have a larger body, right? So the groups can have that common theme so that when we are talking about a medical problem, other people can benefit. So a good story that I always tell is about a diabetes group visit that I had, where I'm, you know, sitting talking with people about, we were talking about insulin, and, you know, somebody said, well, what's the best way to carry your insulin on the airplane? And I'm not a diabetic, I don't use insulin, but guess what? I had like 10 other experts in the room who probably have been on airplanes and carried their insulin. So they're giving their stories. They're giving their stories about how do you do that, right? We are resourcing the group. What better advice to get than from your peer who lives that daily experience that you do, that peer that has to use insulin, right? So there's some things that as a clinician, I might know in my head, but it doesn't mean I have a felt lived experience of that. And yet the group can hold accountability as well. So that is why it is so important to resource the group. So, you know, before our groups, there's time for individual questions. After our groups, there's time for individual questions. And even during the groups, we want to address individual issues, but everybody can benefit from that.
We wanted to, again, thank you for such a wonderful Grand Rounds presentation and all this amazing work and research, and we look forward to hearing the findings of the Optimum study. Emma, if you can just spotlight me for a moment, I just wanted to, and so we just wanted to conclude again with a few just final remarks. One is, please do register for our Integrative Medicine Network Forum. You can see the background behind me, the lived experience of depression. This on November 11th and 12th. You can go to the Osher Center website, www.oshercenter.org, to register. We are accepting abstracts. If you have abstracts for your research that you would like to present, please submit them. The deadline is tomorrow, end of business of tomorrow. So we would encourage you to submit. And this is going to be a wonderful, exciting forum. Second, our next grand rounds will be on November 1st, Tuesday, November 1st. It will be by Dr. Meir Nair on whole body hyperthermia and depression. Please, we would invite you to join us for that as well. And then we also have the T32 fellowship. If you have, if you yourself are interested in applying for the fellowship, or you know a candidate or somebody who is a potential candidate, please encourage them. Those applications are due October 10th. So again, Paula, thank you so much for such a wonderful discussion. Paula has made herself available. So I know there are several other questions. Please reach out to Paula directly. This presentation will be posted on the Osher Center website in the upcoming week. So it'll be available for everyone to view separately as well. So with that, thank you. We will see you next month. And again, please register for the network forum.